So my second presentation, I was asked to talk about the GI oncologists of the future. What is going to happen 10, 15, 20 years from now? And you know, it's interesting when the best predictor of future is kind of performance of the past. What did we think would happen 10 years ago? 10 years ago, people might have thought we might have flying cars right now. We don't have flying cars, but we have the iPhone, which was started in 2007 actually. So I think it shows us information, the use, how we connect with databases is a very critical part that will change in the future too. So I believe that one of the most critical differences between now and what's going to happen in the future is how we interact with patients. How patients will have access to medical knowledge, to physicians, to their care. I believe that within 10, 15 years, patients will wear devices which will continuously monitor their performance. Will in clinical trials and in real life practice will have continuous information transmitted from patients into our hands so that we can look at toxicities early, can modify treatments early, etc. Patients don't have to wait to come back for, let's say, 3 or 4 week appointment. That's going to change dramatically how we interact with patients. Then there are other things. I do believe that immunotherapies that are on vogue right now will make inroads into cancers that are not immunogenic right now. We'll develop tools to get the T cells into the tumor, activate immunogenicity of cancers, and really use immunotherapy in virtually all solid tumors in first line. I don't think chemotherapy will disappear, but chemotherapy and immunotherapy will work hand in hand. The third point is we'll have different diagnostic tools. Right now, when we look at tumor markers, we'll talk about CEA, CA19-9, etc. We'll change things. We'll look at more tumor-based markers like circulating tumor DNA, like DNA methylation markers. This will completely change the way how we follow patients after surgery, for instance. We'll not do imaging scans to look for potential metastases that might appear. We'll look for circulating tumor DNA or other markers that might come up in the future to really monitor patient over time, get rid of CT scan, get rid of MRI imaging over time, but only use them when we identify that patients have a surge in their circulating marker that we're following, and then identify whether this patient might be a candidate for surgical intervention. So we'll have the interaction piece, which will change how we interact with patients, more access to detailed information about patients and databases connected with their cancer. Secondly, the circulating markers which we will identify. And thirdly, of course, the immunotherapy that will make inroads into more and more cancers.